Hello. Welcome to Kindly Neurodivergent with Kay. This show is to spend quality time with each other, kindly discussing the similarities and wide range of differences we experience. The experiences we discuss on this show are for educational purposes only. Please do not substitute for professional medical advice, diagnosis, or treatment. Before we begin, I respectfully request that if you witness any pauses during this show, please continue watching. I'm composing a spontaneous comment or question, someone processing their thoughts, in addition to repeating something that was unintelligible or misunderstood. It is natural discourse, and we can choose not to say anything while this is occurring. Today I have Becky Kreuzer with me. She is here with me to discuss behavior interventions, medication, therapy, and services with autism individuals. Welcome, Becky.
Thank you.
Please introduce yourself.
So I am a nurse practitioner or psychiatrist as well. Like some people call me psychiatrist. I had a degree from St. Francis School of Nursing for my regular nursing degree. And I did maternity patients and pediatric patients. And in 2015, I had a degree at University of St. Joseph's for nurse practitioner. And I have been over this year, I've been working in the Autism Center at Hospital for Special Care. And I do right now inpatient, and I do mostly outpatient, which means outpatient is for people that come to the clinic and see me and do medication management, and then they go home. Inpatient, when I help that, I see patients for a good, 3 to 4 to 5 weeks at the hospital. They're going to be there at time. So mostly I have my primary care is pediatrics, but I do have some adult patients. Some are with autism, and some I have a private practice with all kinds of different mental illnesses like depression or anxiety or bipolar, things like that, ADHD. So,
What is the etiology and pathology of autism?
etiology and pathology, sure. Actually, I have a good little note for that. So autism is a term that is initially introduced to describe behavioral symptoms kind of a long time ago in the 1940s, but they didn't really understand what autism is. Nowadays, there's a kind of an umbrella term. It's called the autism spectrum disorders, right? So there's some are kind of like have different kinds of other features. Some are maybe they call it mild, moderate, or severe, that kind of thing. But one of the shared behavioral core features is that autism affects social communication and includes restrictive and repetitive stereotypical behavior patterns and interests. So a lot of stereotypic, perseverative behavior patterns. Okay. Some clinical features are speech, social interaction, responses to their name. They usually have discomfort with maintaining like eye contact. I said they usually do like repetitive interests, lots of, maybe they like basketball. They just always do basketball, that kind of thing. They usually, the parents usually um, note that they might have autism when they're about like, 2 or 3 years old, because they usually have delay in the developmental speech pattern. So they usually have a lot of like difficulties with speech.
Is too early.
Is too early? Is that what you're saying? Yeah. No, so a lot of times they diagnose autism at about even 18 months of age. So right around 18 months. So they could do 18 months and over. Sometimes people don't know if they have autism or have a developmental program to see if they have autism until they're like teenagers sometimes.
Yeah.
What other symptoms can autism patients have?
Okay. So we were talking about different repetitive and restricted behaviors. Those are, sometimes they have things called stims. Stims are usually like maybe hand flapping or rocking the body or verbal behaviors like repetitive words and phrases. So that could be some of the things that they do. And maybe not seeing eye contact with you. They may not do eye contact. Secondary symptoms, which what I usually see because I'm more in the medical field and these are more of like a severe case, include aggression, hyperactivity, very, very hyper, impulsivity, meaning impulsivity means where you're just going here, there, and everywhere. You kind of don't figure out what you're doing or what you're going to. And then occurrences of like comorbidity such as anxiety, depression as well, that could happen. So those are kind of like more secondary symptoms. We could also talk about a little bit about medical symptoms.
What is psychiatry?
Psychiatry. So that is, so psychiatry are like doctors or nurses that see patients with like medical illness or medical disorders. There's a book called the DSM, as the diagnostic symptoms of medical disorders. So some psychiatrists see patients, like I said, like bipolar, schizophrenia, and that kind of thing.
What is the difference between psychiatry and psychology?
Well, people that are psychiatrists are medical, also like they're medical practitioners, so like a doctor or nurse. And then so when you talk about psychology, that is like they know psychology, like they've done um, courses for psychology. Psychology is the wonders of the brain and how the brain works and things like that. So a person that is a psychologist, that person usually is like more of a PhD instead of an MD. So they're not really more of a medical field. They've done like research in the brain and all kinds of things like that. So psychology, people that are a psychologist would actually do the autism evaluation, like a neuro evaluation, to find out if someone has autism. They would do that kind of thing. So that's something with a psychologist.
Why?
Why do they do the neuropsychology? But yeah, that's just part of their job. They do neuropsych reports, neuropsychology reports. That's part of what some of the psychologists do. So like a school psychologist might do it for somebody that's at school. There might be some that do it at, a clinic or things like that, like Easter Seals does a psychology report and things like that. So they are
You
very,
can't diagnose.
well, I'm sorry,
So you can't diagnose.
me? Could I? Yeah, I could, but they usually want someone for diagnosing autism, especially. They want them to go to a neuropsychologist to do a huge battery of tests. So they're there for about one day they're there for about 2 hours, another day maybe 2 to 3 hours, and they do like these real big battery of tests, and they diagnose it pretty much very much like specialty. But we do diagnose, like psychiatrists do diagnose also mental illnesses as well. But we like certain clinics and things want their autism diagnosis to be very, very good, evaluated a very good way, so that the the patient has the right the right types of programs for them, and school programs for them and things like that.
Makes sense.
Yeah.
How does psychiatry help people with autism?
How did psychiatry help people? So the psychiatrists would help them probably um, help them kind of like coordinate all their care, referrals to care, like referrals to speech therapy, occupational therapy, um, ABA, maybe therapy, applied behavior analysis therapy. Um, so just trying to help their parents, maybe trying to help them with some of their medications if they need medications. And also autism disorders have a lot of sleep disturbances. Sometimes they don't sleep very well. They have a lot of GI disturbances, gastrointestinal, like a lot with the stomach and things like that. And then sometimes they even have epilepsy as well. So we are more medical, the psychiatrists, people in the care. And we also refer them and try to make sure that we have the whole, um, the whole gamut of services, you know.
So it is better than a pediatrician.
So a pediatrician is just more of a general doctor. So they're going to see more people that have like, they see the flu and the vaccinations and things like that. But some pediatricians do some medical management with autism patients. They do help them a little. But I think when they're really a lot of times pediatricians refer um, usually children, to our clinic is because they kind of don't manage this patient very well. They're not sure the client isn't doing very well, so they may refer us to like we're more of a specialty.
How common is autism?
How common is autism? Let's see. Figures in the United States show that 1 in 54 children are currently identified with autism. Now, this study was undertaken during 2009, 2017, because this is a medical journal that I have. So it said approximately 17% of children between the ages of 3 to 17 have an established developmental disability, such as autism, attention deficit disorder. So
How
they
common is
also
late diagnosis?
the what?
How common is late diagnosis?
Late diagnosis. It's kind of rare. We don't usually see that too much. Where we see a patient usually knows when they're about like I said, 2 to 3, even kind of 4. Usually when they go to school, sometimes the teachers say to the parents, I think that maybe you should have like an evaluation.
How is psychiatry different than other specialties where you cannot get insight by running an echocardiogram, MRI, etc.?
Yeah, so psychiatry, we look at symptoms, we look at the parents' evaluation, like an interview, maybe a children's interview. So basically, like if I was having a patient come to see me, I was gonna see the patient. So maybe the patient's only 4 years old, and the parents are there. The 4-year-old's running around, right, and doing toys and things like that. But I kind of listen to them because I've seen pediatric patients for a long time. So I still can see how they interact with me, how they interact with their parents. And then I also do the interview with the parents. And also I look at notes and things from the teachers and things, or from the daycare or something. So with maybe, like you said, like say somebody has, an MRI. So say somebody has like a brain tumor or something, it's gonna be like more, it's going to be more medical. It's going to be more tests. So you might do the MRI, then they look at the brain scan. So you really can't do like a brain scan for autism. So that's not what happens. So it's more like the interviews, like I said, in the patient.
Like epilepsy.
Yeah, yep. And sometimes we have our patients do, like for epilepsy, we have them do EEGs, we have them do echocardiograms because we want to make sure that their medications are working well. So we actually have those things. So we use those, but that's not getting, give them like a diagnosis of autism. Yeah.
The autistic brain does not look different.
Not usually, but there are people that have autism that might have genetic disorders, or they might have other brain symptoms like fetal alcohol, or sometimes I've had kids, different kinds of birth things, or genetic components. There's genetic factors and things like that. Yeah. So we don't do like a brain scan or anything like that.
I'm surprised. I didn't realize.
Yeah. There's a couple of
How do you
different,
treat some of these symptoms?
how do we treat them? Yeah, so the different symptoms that we we were talking about maybe, different behavior patterns and things like that, or kind of like, we're talking about like aggression and things like that, right? So if somebody's aggression, they're biting others, biting the parents, or, you never know when they're like, and they might do things like punching or things like that. So that would kind of be aggression, right? Or kids that have hyperactivity and impulsivity, right? So that's kind of like an ADHD kind of person has hyperactivity and impulsivity and things like that. Or maybe they have like some depression, or they feel, a little bit sad or something like that. So there's different medications that we use for all of those kind of symptoms.
What do you
So
consider function of a behavior?
the function of their behavior. Mhm. So probably, like I had said, some of their behaviors might be repetitive, restricted behaviors, right? So just repetitive. So,
What do you
uh,
consider function of a behavior?
yeah, so an example of that might be, say, repetitive behavior might be like doing a video game. And they have to do a video game, a video game, a video game, a video game, right? And it's so they have such a big repetitive feature of that the parents had said, no, I'm going to give your computer away or the video game away because that's all you wanted to do. Then what happens? Like, what would the behaviors would that be? Would they be aggressive? Would they say no? We don't know. So we have to see. So that's part of the interviews, right? That we talk to a lot of the parents, like what's happening with those kinds of things.
How do you determine if someone needs medication and or other treatments?
Yeah. Well, I think that especially when they come to us because we're a specialty, they've already talked to their pediatrician. They've talked to like the teachers and things like that. So I think that after all of that, we're really knowing what kind of behaviors that we would need to treat. So say maybe like ADHD symptoms. So hyperactivity, impulsivity, they can't listen, they can't do anything at school. We might use a medication for ADHD. So it could be like intuitive, or it could be like Concerta or some things like that.
Does the symptoms have to rise to a certain level to be considered for medication?
Um, it could in a way. I think it depends on, say, different factors. So how is that patient in school and how is that patient at home? So you want them to have the same kind of behaviors at home and school. Because other than that, if they don't, you might say maybe it's what's going on at school, maybe what's going on at home. So you want to see those kinds of behaviors, you know, when they go to a store, when they go to school, when they go to home. So maybe that level is like, a level 8 of, say hyperactivity or something where it's everywhere, in school and home and work and all that kinds of things, right? So that's when we might use medication, or the teachers and the parents really say, we really need to do this medication to help the client, right? We're helping the patient.
What helps you differentiate all these disorders?
Well, we do when we had our our school, we have to study the DSM, we have to do internships and medical school and all those things, right? So we really have to really absorb those kinds of diagnoses and things to diagnose things, right? So we have to learn the diagnoses and all the symptoms and the factors. So if you, like I said, the DSM is like a big Bible, right? You want me to go take a look? I can take it. Might be at you look at right B. It might be at work. I thought I had one here too, but it's a pretty thick book. And it has all the different symptoms. So sometimes you might think, you're not sure what the symptoms are, and you can kind of look in there if you need to, as a practitioner, you know.
What is the difference between mood stabilizers, anti-anxiety, antidepressants medications along with other agents?
Okay, so like different kinds of medications that we might use. Okay, so we might use we talked a little bit about what ADHD medicines. We just talked about that. We might talk about antidepressants, which help with the serotonin in the brain. So all of the medications that we use, a lot of them enhance the neurotransmitters in the brain. So the neurotransmitters. So I always say like the neurons, which is the cells in the brain, are kind of like this. So you have like these big, octopus hands and things like that. So they kind of go like this, and the neurotransmitters are the little like hormones or something that kind of like zap these neurons that keep them going, they keep them thriving, right? So the neurotransmitters are dopamine, serotonin, yeah, norepinephrine, okay? And some of the medications that we use help enhance that, okay? So it might help enhance those kinds of things. Maybe less dopamine, more dopamine, more, less serotonin, more serotonin, okay? So we do those, and then mood stabilizers help the mood, right? Help the person's mood, so it's stabilized. So it's like you're not like, cycling. So a mood stabilizer is more for a patient that might have like a bipolar event, like a bipolar, or like a cyclothymic event, meaning cyclo moods. So that might be somebody that's like not really an autism patient, but there are times that an autism patient might have like bipolar symptoms, where they might have manic symptoms, just bipolar, and they might need a mood stabilizer. Sometimes we use some mood stabilizers for aggression. So if the patient has aggression, where there might be, like I said, biting, kicking, or hitting or something like that, some of the mood stabilizers help calm them, and they help them stop doing those kinds of things. Anti-anxiety medications too, because sometimes there are patients that have autism that have a lot of anxiety. They're a little bit worried. Maybe some of their their symptoms of autism might worry them a little bit, right? They don't, neurodiversity, right? And autism is kind of like that. Just means that there's different types of minds that take different approaches to express themselves, right? So different kinds of minds. So my mind, your mind, a lot of people's minds. Um, so maybe they're really worried about how they were, how they are, or how they feel, or what other people think about them, that they have a little bit different mind than we have. So maybe they have anxiety. So they might need a little medicine to help them, calm some of their anxiety.
What's the difference between aggression and behavior?
It's probably the same when we talk about that, like in our journals and things. We kind of talk about like this person is having, you know, their target behavior, meaning their behavior is probably like their aggression. So it's kind of like it's kind of the same in a way.
How do you determine if the medication is effective and or affecting other symptoms?
Yeah. So we usually kind of track things. So we usually get a lot of our patients have um something called like an ABA you know um behavior specialist, guess I could say it. And they may do like a big track like this. So they might do something like this. So they may do that kind of a check. I don't know if you can see that well. So it might be, see, like this big kind of like a behavior. So those are the behaviors of the big mountains. And we want to keep it more steadily, right? So we wanted to know that maybe they're not like, say they were at school and they were all like running around or leaving the classroom or having some of those like maybe aggressive behaviors. So we kind of track them by giving these kinds of like these papers that they gave us, that helps. And we might talk to the parents and say the parents are like, oh, the child is doing really well. They're doing good. They're going to school. They're at home. They're doing their thing. They're going to bed well, those kinds of things. So we just kind of track those behaviors in our appointments, I'm trying to say.
How do you determine if agents are working versus the patient not taking it?
Oh, if the patient is not taking their medications, right? So that's kind of hard, right? As a practitioner,
Yeah.
we don't know if someone's not taking their medication. I think if we figured that out, we may able to do some kind of bubble wrap. Um, I call it a bubble wrap sheet. So you go to a pharmacy and they might put little bubble things like that you have to squeeze out of. So say like something like you find in the pharmacy where you have to like you have a little paper and you have to squeeze out them. So they might put all their medicines in that little bubble for morning and then they drink it like that. So that might help a patient. Or there are some medications that are injections. So if patients aren't really using their medications and they're not, they just are, they just forgot or what happened, they can get an injection for medication as well. So that might help.
They try to not let you to not get that information.
Some of the patients, well, I think if the parents were like maybe embarrassed about it or something, then maybe sometimes, things are kind of chaotic. You might have maybe a lot of different kids. Maybe you have like 5 kids, and parents are like, I've just been so busy, with everything. So maybe maybe the parents might be a little embarrassed and they might not tell us. But we try to do our best at the clinic and saying, are you using this medicine? So hopefully we can figure it out.
I mean, are you always allowed to ask the pharmacy?
Yes, we can. So we can look at the pharmacist, we can call the pharmacist and ask when they dispense the medications. Yeah.
Why do people with autism respond to psychiatric medications differently?
But they might have things differently. True to all kind of patients with like mental illness. Some of our medications can be different with other people. Could be, with an autism patient, it could be not. It could be because of genetic differences. So sometimes people have certain kinds of like in the liver, I could say, the liver doesn't process certain medications well, so that they may need to have a different kind of medication. So we can use, if we need to, sometimes we use like a genetic testing kit that might help us see if the medications might work or not. But we kind of use a certain kind of formula that we use that autism spectrum disorders patients do well with blank kind of medication, a certain kind of medication for this kind of blank behavior, right? So we kind of know, in medicine because we've done it for so long and we have studies. So that's why we use certain kinds of medication.
When is off-label prescription use appropriate?
It can, and we do talk about that with our evaluations. Yeah, we definitely talk about that. A lot of patients use maybe something that has like fish oil or, calcium. Um, some people use magnesium to help sleeping, calm, CALM. That is a magnesium kind of a supplement. So yeah, some people do vitamin D. Some people do
Essential oils.
they may do like an essential oil too, right? So maybe like calming, right? Lavender and those things. So those would really help as well. Yeah. In the hospital, we always look at people's vitamin B12 and vitamin D. And sometimes we supplement that if we need to, because those are really, we really need those kinds of things to help patients and help their neurotransmitters to work well.
Do you have to discourage off-label use?
I guess if it was something that seems like it's maybe not right, right? If it's certain things um that we found like in a study that it really doesn't work, right? Then we might need to stop off-label use. If sometimes we're going to use a certain medication and the off-label is like kind of the same thing, then we have to talk about that as well. But definitely, like you said, like, scents and essential oils and things like that. If the patient likes that, like there's a certain types of autism patients that might not like, certain smells. They might not like certain kinds of foods. That helps a lot too. I've heard that. So you're not exactly sure if they would like that, but they might, right? If it helps them. Anything that helps people, we want to encourage it.
How do you consider what is reasonable?
What is reasonable, like as far as off-label kinds of things. Yeah. Um, I think that I
Every
think we do. Oh, sorry, go ahead.
everything.
Oh, everything. Okay. So I think we would probably, like, remember I was saying that big whole look at the patient, right?
Mm.
Almost like a pie. Like when you think a pie with little squares, right? Or I'm sorry, triangles in a pie. So you might look at all those different things that they're doing, right? And how are they all working? So you might look at the patient and say, how is this working? How is that working? How is this working? How is that working? Maybe this is not working. We should try something else. Sort of like maybe somebody doesn't like food well, and they haven't ate well. They have, their vitamins are low and things like that. Well, they might need like a supplement like Pediasure, right? Or something like that, right? Yeah, there you go. So they might need that for their vitamins and things. So we have to really like look at that big pie and say what is reasonable, what are they, what is helping them, what is not helping.
I used to.
Yeah, it helps a lot, right? With your vitamins and everything.
Why is autism and psychiatry a very unique topic when looking for providers?
Yeah, it is very unique. I think that maybe people don't do that specialty, or but maybe not know it as well. Maybe they didn't do it in their internship. They might not have seen, autism. And I think that there isn't a lot of autism centers. I didn't really tell you that, but our autism center, a hospital for special care, is one of the only ones in the whole entire, like, I would say probably the eastern area. We have patients from New York, New Jersey, Massachusetts, even some patients like from the South. And because so it is kind of unique. And thank goodness we had, wonderful grants, and the state of Connecticut has really helped us. State of Connecticut actually has one of the best autism services around. A lot of patients have told me that they actually moved to Connecticut to help their child.
Why is it uncommon to have an autism center?
Yeah, well, I think that we just don't have them in other states. Maybe they don't have the grants or the funding for it.
Thank you, Becky, for doing this with me. It was great to have you on. Please share this talk show with your family, friends, clients, and colleagues. Everyone watching, don't forget to like, follow, subscribe, and share on Facebook, Instagram, and YouTube.